First Responders and Suicide Prevention webinar presented by the Disaster Distress Helpline and the National Suicide Prevention Lifeline. Here we go. I think, maybe. Okay. My name is Lidija Hurni, and I am the coordinator of best practices in disaster mental health for the DDH, and I will be the facilitator for this webinar this afternoon. I'd like to begin by telling you that the DDH is a program of the U.S. Substance Abuse and Mental Health Services Administration, or SAMHSA. It is a subnetwork of the National Suicide Prevention Lifeline, and both are administered by the not-for-profit Vibrant Emotional Health. As such, the views, opinions, and content expressed in today's presentation do not necessarily reflect the views, opinions, or policies of SAMHSA, the Center for Mental Health Services, nor the U.S. Department of Health and Human Services. So before we begin the webinar, I'd like to review some logistics. First of all, this webinar will be recorded, and the recording will be made available to Lifeline and DDH centers on the Network Resource Center. Closed captions are also available and can be accessed by clicking on the closed caption option via the Zoom dashboard. And so if you scroll down, if you take your mouse and kind of scroll down to the bottom of your page, the dashboard should appear and you should see CC that you can click on and access closed captions that way. If you are joining us on the phone, please be sure to mute your phone. And same goes for computer audio as well. And if you are on the phone, please do not put your phone on hold. Sometimes that causes background music, hold music to play, and we certainly don't want that as a disruption. All attendees will be muted during the webinar. However, you can still be a part of the conversation and ask questions by using the chat feature on the Zoom dashboard. Again, if you scroll down, you can find the dashboard. So we may answer your questions in the moment as they come in and as you ask them, or we do have some time set aside at the end of the guest presentations where we will answer your questions and have a discussion that way. Okay. So to just go through the agenda, we're going to begin by going through an overview of cultural characteristics and norms among first responder groups. We're going to also discuss common stress factors or stressors faced and risk factors for distress and other mental health concerns. We're going to discuss strategies for crisis counselors working with first responders, and also resources available to Lifeline and DDH crisis counselors in supporting first responders. And then, like I mentioned, we do have some time at the end for a discussion and Q&A with our guest experts. I'd like to now introduce you to our guest experts. Going first will be Dr. Chris Caulkins. He is the Executive Director of the Strub Caulkins Center for Suicide Research and has research presented and published on suicide at a state, national, and international level. Dr. Caulkins is a practicing paramedic for the city of Woodbury in Minnesota and is the Emergency Medical Services Program Director and faculty member at Century College. He has over 25 years of experience responding to 911 calls for suicidal ideation, attempts, and sadly, deaths. Rhonda Kelly served 17 years as a firefighter and paramedic with Aurora Fire in Colorado while working part-time as an emergency room and psych ER nurse. During the last 5 years of her career, she served as the health and safety officer for her agency, developing a special interest in responder mental wellness. Recognizing that this issue required larger support than any agency or single branch could manage in isolation, she proposed an initiative which evolved into an organization known as ResponderStrong, which works across branch boundaries to improve mental health supports for responders and their families. Joining us also is Shye Louis, who's the program manager for clinical best practices for the National Suicide Prevention Lifeline. And Shye will share with us resources, or a resource that the Lifeline has developed for centers working with first responders that will be available on the NRC in the upcoming months. Okay. So let's begin first by hearing from Dr. Caulkins, who will discuss with us first responder culture and norms. So Dr. Caulkins, I'm going to stop sharing my screen, and you should now have access to begin sharing yours.
Okay, give me a second here to key up. Bear with me, just getting the file out of my Dropbox here. Sing a little song, and I think should at least line that. Okay, great. So thanks for having me. Sorry for my little technical difficulty there. So my job here is to talk a little bit about culture and what that is. This is a fun thing for me to talk about. Part of my background is I'm also qualified to teach anthropology, so I thought this is really cool. I get to use that piece of my brain too. So culture in of itself is, even amongst anthropologists, is kind of debated about what that is. But my favorite definition is knowledge, belief, arts, morals, law, custom, and any other capabilities that and habits acquired because of belonging to a particular group. And in this case, it's the emergency responder group, and it is a culture and several subcultures there as well. It differs between agencies. It can even differ between stations or branches. So for example, in the fire service, which I was a part of for 14 and a half years, different fire station or even a shift within a fire station can have a very different culture. So why it matters? Really, I'd refer you to Bandura's social cognitive theory. And I use this in my dissertation, actually, which was, and this is what I found as a result of that there's a reciprocal nature between education, our culture, responding to emergencies, our response to psychological trauma and suicide calls, and our own. So all of those things matter. So reciprocal determinism is the key to that. So I'll go off to emergency responder culture overall, and then I'll split it into different disciplines. So all cultures are very alcohol permissive. I always tell people, if you want to see maladaptive coping mechanisms, go to an emergency medical services, I call it EMS, we all call it EMS, conference, and see what they do after hours. You'll see a lot of maladaptive behavior. There's a lot of cynicism, macho-ness, compassion fatigue type stuff, which results in a lack of empathy. Of course, there's the dark humor, which if you're not in our profession, can really come off the wrong way and bad if you drop into it. We're very skeptical as a group. We use a lot of irony and sarcasm. That skepticism also, we're going to talk about, I know this is sponsored by the National Suicide Prevention Lifeline. Part of the skepticism that I've come across is that responders are reluctant to even use that line for fear that the line will ultimately send our own people for us if we express suicidal ideation, things that could be a barrier, because we're on the other end of that, where we get calls that were sometimes initiated from there. We're adverse to help seeking a lot of times, In fact, in a study done at the University of Phoenix, there's some interesting statistics. 39 respondents said there's negative consequences at work for seeking mental health assistance. 55% say their supervisor will treat them differently, and 45% say coworkers will consider them weak. And 34% say they'll be passed over for promotions. At this very moment, I'm actually find myself in that awkward position. Because of disclosing, and I freely disclose all the time, that I have post-traumatic stress, depression, anxiety, and I'm suffering repercussions now. So it's a very real thing. We only show outsiders kind of the tip of the iceberg. That includes our significant others. There's kind of we want to protect them. We don't want to offload everything. And sometimes mental health providers will say, go ahead, tell me, I can take it. And we kind of think of that as throwing down the gauntlet, like challenge accepted. Sometimes, some of us. Others of us still hold back because we're actually worried about the mental health of mental health providers, secondary trauma and causing things like that. If we really opened up, I think a lot of people would have difficulty, or at least that's my perception of it. And maybe some of the other folks feel differently about that. And then, of course, we have attribution biases, which lend to compassion fatigue. So I always go into this X-ethnic neighborhood, and it's always these type of people that cause these problems or have these issues, and we forget there's all kinds of good things going on in those houses all over the place. We just get called to the bad things, and then we attribute them incorrectly. So that's a phenomenon, too. If we go into law enforcement culture, it's called the blue culture. And the blue culture, you often hear the thin blue line. That represents police on one side, law-abiding citizens on the other, and police and law-abiding citizens on one side, and then criminals on the other, and the concept that they're there to protect. Blue wall, it's really about a code of silence that sometimes protects those members with ethical or potential legal problems. Such as the domestic violence further down in the slide here as an example. It's also cited as the possible reason that suicide amongst law enforcement officials hasn't been as robust as it could be. But we think that's loosening up because mostly because of the release of Sheehan and Warren's 2001 report there with the FBI that's called Suicide in Law Enforcement. We think that's probably helped loosen things up a little bit. In general, they have a more aggressive stance with the public. Their training advocates control, aggression, authoritism, all this stuff that's being worked on. There's different kinds of trainings, and in my state, for the first time ever, there is a peace officer standards training requirement that officers need to have X amount of training in mental health, suicide prevention initially and then ongoing. Domestic violence is a problem, often tied in with substance abuse, and there's quite a volume of research on that. I will also add that murder-suicide is not an unknown phenomenon in law enforcement, and it's a very uncomfortable thing to bring up. But there's enough there that an entire book was written by Linars, and you can see the spelling of that up top, his last name, on that topic. It's scary stuff. When we get to the fire service, oftentimes it's called the brotherhood. Now we call it brotherhood, sisterhood, but you still hear brotherhood thrown around a lot. The cultural construct is honorable character, relentless courage, selfless courage, those kinds of things. It's a more aggressively risk-oriented than EMS because we attack fires. There is some element of risk. So aggressive risk, not aggressive towards people necessarily. And I'm allowed to say this because I retired off the fire department. I don't know if I would say this to other firefighters if you're not one, but 200 years of tradition unimpeded by progress. We kind of wear that like a maladaptive badge of honor. At least in my area, everybody throws that out pretty liberally. There's also something referred to as the firehouse effect, which I've seen on multiple occasions. And that's defined as firefighters who talk to each other for too long, come to agree on many things that an outside impartial observer would find ludicrous, a type of group think. So that's an interesting phenomenon that I've seen in action. It does happen in EMS a bit too. Firefighting is a team sport. It's a family-like structure. They eat together, sleep in the same areas together, do things together. So much more like a family type structure. If we get to emergency medical services, we're storytellers. We have lots of anecdotes, lots of dark humor as well. We tend to embellish those stories quite a bit. We're storytellers, like I said. There is the EMS grapevine. So if you want anything spread around, just say it in an EMS space and it will be all over the place in no time. We tend to be very small communities. So even in the area I'm in, which is the Minneapolis-St. Paul area, there's only 3,000 paramedics in our area. In the state altogether, and the huge majority of those are in the metropolitan area. So we're running into each other in the emergency department in trainings together, et cetera, over and over again. We've educated at the same colleges, et cetera. There is such a thing as occasionally patient punishment, and that's uncomfortable to acknowledge. Bledsoe just recently did a piece on people using Narcan as punishment to take people's high away, or in some cases put them into a withdrawal. Myself, just a one-off story, when I worked for one ambulance service, not my current employer, we had to take the 14 gauge needles, IV catheters, off the ambulance, and those are some of the biggest ones that we have to start an IV with, because people were using them, paramedics were using them to punish people they didn't think warranted ambulance transport. So the supervisors ended up taking them off. And that's a one-off story, but I gotta believe it happens other places too. We're very superstitious by nature. If you say, this is sort of like, actually it's like mental health care providers and emergency department people, don't walk into an ED and say it's quiet. Don't walk into an ambulance space and say it's quiet. Everybody will hush you. Sometimes we couch that in a joke, but I think there's an undertone of seriousness there. We also tend to believe odd things like the moon causes mental health crises. But then again, in a research project done by Snelson in 1995, 43% of mental health care providers bought into that myth too. And for anybody thinking it's true, it's been debunked over and over in my research. We do have a lot of ADH-like behavior. It's the perfect career for that. I see this on the street, but I see this in my students all the time. It doesn't mean we necessarily have ADHD, although that is high. But it can be features, as you all know, of other issues like depression, et cetera. We are drawn to the profession because, get on a call, maybe an hour exposure time, unless you're in a rural area, to the call, write your report, forget about it, move on to the next thing. So that's really conducive to that kind of personality or that kind of a behavior. I would also say, I forgot to mention that all responders, the research shows that we all have, most of us have higher ACE scores statistically, adverse childhood events. So it seems like we're self-selecting into these professions. We don't like what we call BS calls, and that's like behavioral health calls, things like that, or things that we deem are a waste of our time, even though they may not really be a waste of our time, even though somebody may really need help, and that's where the compassion call fatigue comes in. We have, and the police have like I think I forgot to say, but like a friend type structure where they come together, separate, come together, separate if they're not in two officer configuration or 2 officer car configurations. But EMS is much more like a marriage structure. We're together, you're like a couple. Sex doesn't matter. You know what the other person's anticipating. I don't have to communicate with my partner what's necessarily going to happen next, what I'm thinking. If I've worked with them for a period of time, they know pretty much what I think. I know what they think. And we know how each other's going to react. And we know when each other are even mad at each other. So that's something that's very real too. My very last slide, we haven't addressed telecommunicators, and there's not a lot of data on this. So the emergency dispatchers, the 911 dispatchers, but they're the great forgottens. And I just want to shout out to them and say that I think they suffer a lot of vicarious and secondary trauma, and I think they're really hurting, and there's a serious dearth of research to even look into it. I mean, there's next to nothing. So we really need to help those telecommunicators. They face a lot of the same things that the other responders do, and maybe even worse, because at least I show up on a call and go, oh, it's as bad as the dispatcher, oh, it's worse, or oh, it's not as bad. The greatest fear always is that of the unknown, and you build something up in your mind. If you don't get that closed loop, find out what happened, your mind builds things up. So that is what I have to say. I'm getting ready to stop sharing here, and I'll move on to the next person.
Great, thank you so much for that very useful information and description. Our next topic is common stressors faced by first responders and risk factors for distress. Rhonda Kelly, the founder and director of ResponderStrong, will be covering that section. And Rhonda, I'm going to stop sharing my screen and my desktop that has way too much stuff on it, and I will allow you to share your screen.
Great, thank you. Can you hear me?
We can hear you, thanks.
Wonderful. Thank you for the lovely introduction. So I'm going to run through a series of statistics here. I'll run through them quickly verbally, and they'll be accompanied with slides that I feel the visual just helps increase the retention and the impact of the statistics. So bear with me here. There's quite a few slides, but we'll get through them quickly. You may or may not be aware, suicide has been recognized as the leading occupational killer of law enforcement, fire, and EMS. As Chris alluded to, we suspect it is also for dispatch, but there is a dearth of research highlighting that profession. We know they suffer significant amounts of vicarious trauma, and that they are compounded by the fact that they are in a sedentary position. They are not able to expend the stimulation of the nervous system as other responders can through physical movement. So there's quite a significant impact on dispatch from their vicarious trauma exposure. We also know suicide, as reported across branches, is vastly underrepresented. We believe we're catching about 40 to 45% of the actual occurrence for a lot of the reasons that Chris so clearly outlined in his culture piece. Our cultures deeply stigmatize any signs that can be interpreted as weakness or ineffectiveness in the role. Oftentimes, emotional or mental impact are viewed as signs of weakness and unfitness for duty. We know now, even based on the statistics we have, that law enforcement and fire are 3 times more likely to die by their own hand than by all the other line of duty death causes combined. And again, the fault for that does go back to our culture. We know the emergency response professions are hazardous by nature, but we've seen time and time again, when we recognize these hazards and we train for them, we do minimize the deaths caused by those line of duty occurrences. Our problem with our culture has been that we have steadfastly ignored our greatest exposure, which is emotional trauma and suffering and intense suffering of others. Being compassionate, being empathetic make us competent to do our jobs, but we haven't acknowledged that those are pathways for injury. We also recognize that so many people feel that they're only entitled to experience emotional or mental reactions to the significant events, whether that be Columbine, the Pulse nightclub, something that made national news. What we find is over the course of responders' career, it's actually cumulative stress injury that damages more responders, and while being embedded in a culture that doesn't allow them to acknowledge that. A brief rundown: Colorado Office of Suicide Prevention did a survey from the Violent Death Reporting System, 2004 to 2014. During that decade, they looked to see how many Police officers, fire, EMS, dispatch, and security died by suicide. When you look at those figures compared to the line of duty deaths, 71 officers died by suicide compared to 25 other line of duty deaths during that time. The statistics are frightening, yet we know that using the death certificates and the usual occupation line, the entry, we miss we miss actually all of the volunteers and many retirees who've transitioned into a second career. We also may miss responders who quit or were terminated for cause in their profession. Following up on this study, there are some really concerning statistics. Overall, in that time frame, 49% of Coloradans died by firearm. 73% of the responders died by firearm. We know access to lethal means is an issue among the emergency response community. When you look at suicides by age, the blue are all suicides in Colorado. The green are emergency responders. So we see a peak in the 25 to 44-year-old age group, which is the bulk of our workforce across all the professions. We also see a subsequent peak after the age of 65. Retirement, we know, can be challenging for many reasons. In the emergency response professions, that separation from identity, responders truly identify with their roles. I am a cop, I am a firefighter, I am a paramedic. When we lose that identity without having another identity in place or a broader identity to transition to, we really risk taking some significant hits emotionally and mentally. In addition to that, we often find we no longer have the schedule, we no longer have the social support, we no longer have the structure, and we no longer have the resources that helped us keep the cumulative career over our trauma at bay. So now in retirement with a lost sense of self, we find ourselves floating around with the impact of a 20 or 30-year career. When we look at this statistic, veterans are entrained into the emergency response profession at a much higher rate than any of the others. Nationally, vets comprise about 6% of the workforce. In law enforcement, it's about 25%, fire's around 21%, EMS is around 12%. And when we looked at those statistics in Colorado over that decade, in Colorado, 20% of the suicides were veterans. Among emergency responders, 46% were veterans. So we know we've really not effectively served this population, that they are many times coming in with their own stress injuries and trauma from their prior career. And now they're working in an environment that provides a significant number of triggers while also not allowing them to speak about it. Nationally, the numbers are on parallel with what we saw in Colorado. For several years, officer suicides in law enforcement have significantly outpaced the other line of duty death causes. When we look at fatal shootings of officers by others versus officers who take their own lives, there were 52 fatal shootings of law enforcement nationally in 2018, yet 159 reported law enforcement officer suicides. And again, recall that number we suspect is only 40 to 45% of the actual occurrence. The fire service is also 103 suicides were reported in 2017, 98 in 2018. These far outpace the other line of duty death causes. We rely heavily on Joyner's interpersonal theory of suicide to explain how people who were pre-screened into these professions, people who passed psychological evaluations, physical evaluations, medical evaluations, and are embedded in organizations that perform high levels of training, how they wind up dying by suicide and suffering with other signs of poorly coped trauma, depression, anxiety, substance abuse, at a much higher rate than the rest of the population. If you're familiar with his work, he talks about two senses that lead to individuals contemplating suicide: perceived burdensomeness and thwarted belongingness. But to actually develop the capacity for suicide, that has to be acquired. And what we find in the emergency response professions is all of these jobs train responders to put others' safety ahead of their own. They train them to override their inherent sense of self-preservation, to go into the burning building, to chase someone who's shooting at them, to wade into a bloody scene and attempt to resuscitate or assist the patient. They're also trained that they can't quit in times of discomfort, whether it's being tired, being hot, being fatigued, being injured, that the job comes first, they have to move forward. All of these things serve over time to erode the responder's sense of self-preservation. When we look at the correlates of suicidal thoughts and behaviors among firefighters, again from Thomas Joyner's school, He surveyed more than 1,000 firefighters. 46%, excuse me, admitted to suicidal ideation during their career. 19.2% admitted to having created a plan. 15% admitted to having made an attempt. And 16.4% admitted to participating in non-suicidal self-injury, an attempt to numb out the internal pain that they were feeling. A fabulous survey that came out of GEMS a couple years ago talks about the impact of culture. And I find this to be frightening, but very reassuring at the same time. In this study, more than 4,000 EMS personnel, 37% admitted to contemplating suicide during their career. That's compared to the CDC's national average of 3.7%. So EMS providers outpace that by tenfold. When it comes to attempting suicide, 6.6% of the EMS respondents admitted to having attempted, compared to 0.5% of the national population. This is the encouraging slide. What we see here is rankings of culture from left to right. No encouragement and support to cultures that had full support of management, full support of the line personnel, and also had resources readily available. When we see the no encouragement or support, obviously the suicide contemplation rates are significantly higher, 56% of individuals in EMS professions with no encouragement or support in their culture admitted to contemplation, 12% to a suicide attempt. But when we move to the right, cultures that openly support acknowledging the stress injury, acknowledging the trauma, and guiding members to help, the rates of suicide contemplation were halved, and we see the suicide attempts cut to 1/3. When we look at spectrum of mental wellness and statistics across the country, there is a lot of room between being a functioning, healthy emergency responder and being somebody who is on the brink of suicidal ideation. We know that firefighters and law enforcement experience post-traumatic stress and depression at 5 times the rate of the general population. And an interesting figure that shocks many responders is that responder children develop post-traumatic stress at a far higher rate than the average child in the US. Many times responders will shut down when they get home, thinking that they're protecting their family. They're visibly agitated or upset by something that happened during the shift, but they don't want to talk about it. Not talking about it, unfortunately, can lead children, as you know, at their developmental stage to believe that they're the subject of the distress of the parent and to internalize that trauma in ways that neither the parent nor the child are aware. If you're looking for additional statistics on emergency responders and alcohol abuse, we know that alcohol is not only culturally acceptable, but it's actually culturally reinforced as a numbing mechanism. In the EMS community, ready access to narcotics through the medical kits also allow access to narcotics as a numbing mechanism. It's estimated through SAMHSA that 40% of fire and EMS personnel are misusing alcohol in the absence of other coping mechanisms for trauma. Marriage and divorce, tons of speculation out there about the divorce rate. We know that through the work of Haddock et al. And Sarah Janke, the prevalence of divorce among male firefighters is actually similar to the general population, but the current divorce rate among female firefighters was more than 3 times that in the general population. Being a female in the fire service is a very difficult thing. I speak from personal experience as well as from research. Nationally, about 5% of the fire service is female. One of the features of the National Fire Service, and sometimes it is an ineffective attempt at coping with trauma, is bullying. Bullying is very prevalent. It's not limited just to the females, but it's another one of our dark secrets, along with domestic violence, substance abuse, and so many other things that we don't like to talk openly about. It is my personal belief most of this activity is a failed attempt to cope with trauma. Married firefighters, just an interesting side point in that study, are less likely to report heavy alcohol use or depression. When we talk about the risk factors, I think we've covered pretty extensively culture. Our culture deeply stigmatizes any signs of a mental or emotional impact from the work. And I do agree with Chris that there are a multitude of various subcultures, but when we look at the emergency response culture overall, the overarching culture, the macro culture, this is the defining feature. Mental health is stigmatized deeply. We're a very individualistic culture, and we are always looking for who doesn't belong in the tribe, who's weak. We're comparing ourselves to the tribe and comparing the tribe to ourselves. The vicarious trauma exposure is often missed by clinicians and family members who don't understand the true nature of the work. Not only are responders exposed to far greater levels of trauma than the average citizen, they are unequipped. They are expected to manage that on their own without any training and with very, very little support. And as you know, as mental health professionals, that's a recipe for disaster. We know there's a lot of administrative stress, a lot of Monday morning quarterbacking. You should have done this, should have done that. And there's not always a lot of recognition for the stressors and the unique features of the situation the responder was in when he or she made choices. Media coverage, particularly for law enforcement, adds a significant amount of stress. Always being fearful what's being recorded, what's potentially being taken out of context, and how a command, a word, an action in the heat of the moment will be interpreted later publicly. Stress injuries, we have borrowed heavily from the military's combat or operational stress injury model and recognized that there is a better way to address the exposure to cumulative stress for responders. It's basically, if you're not familiar with it, a model that starts in the green, moves to the yellow, moves to the orange, and then moves to the red zone. Each of the signs indicated in it are signs of stress injury and an indicator to someone who is aware that they're sliding towards the end of mental illness, sliding towards the end of significant stress injury, and how to self-regulate or recognize when to seek help. As I'd mentioned, alcohol and narcotics are frequently utilized among emergency responders to numb the internal pain. Effective treatment of that can't be managed unless the underlying trauma is recognized. Another point that came out in the Colorado survey is most responders have ready access to lethal means, so it only takes a split second for them to make a choice that they feel will relieve them of pain, but ultimately takes their life. Stressors unique to the emergency response professions. Schedules. Nobody works a 9 to 5 unless they're in an office position. Schedules tend to shift back and forth. For fire, they may be as long as 24 or 48 hours at a time. For law enforcement, they may be anywhere from 8 to 12 hours or longer and shift frequently from day schedules to evening schedules to overnight schedules. EMS tend to work up to 24 hours and on occasion with overtime or taking trades can extend beyond that to 48 hours or longer. Dispatchers work long hours, usually 12-hour shifts in a sedentary position. It is amazing. I always used to laugh in the fire service. My shift schedule, I worked 10, 24-hour shifts a month, but everything my family wanted to do was on one of those 10 days. And it can get to be an issue within the family. When you miss birthday parties, you miss holidays, you miss other significant family events, and it can start to foster a sense of disconnection and start to break apart the relationship. Sleep deprivation is a horrible feature of all of the emergency response work, not only during the shift, but the hypervigilance that can arise in responders secondary to that chronic trauma exposure can make it very challenging for them to sleep when they're home, constantly aware of a shift in light, a change in noise in the background in the room, being used to sleeping on a different schedule that pulls them away from their circadian rhythm. We know sleep deprivation is a known carcinogen, and we know that sleep deprivation increases the risk of many metabolic diseases and also can hasten the development of depression and anxiety by depleting individual resources. We know that there are flooding of the system with cortisol throughout EMS work or through emergency response work can cause damage not only neurologically and physiologically, but that it can manifest from day to day. Many times when responders are coming home from a shift, their sympathetic nervous system is completely tapped out. They don't have any more adrenal hormones to pump into their system, and they shift into an unmoderated parasympathetic nervous system dominance, which is great physiologically. It's recovery. It helps the body reset itself and regain homeostasis. What it looks like, though, is lethargy, disinterest, fatigue, contempt, things that very, very readily can become the root of issues in relationships. When responders and their significant others recognize this, it can be managed. When it's not recognized, it can be very destructive to the family unit. We talk a lot about burnout and compassion fatigue, and Chris touched on that. The response professions very much encourage taking care of others before self. The whole put your own oxygen mask on first hasn't been a key message in our culture ever. We're shifting that now, but responders oftentimes feel that they're being virtuous, feel like they're adhering to the role that they aspire to when they deny their own human needs and don't understand that that's not sustainable. It will ultimately lead to burnout and compassion fatigue, which will then further increase the negative internal environment. Rescuer mindset, many responders have that attribution bias that Chris so eloquently described. We see the worst days of other people's lives. We see the worst behaviors of humans. And it is very, very easy to generalize that to humanity in general and to believe that we have to be hypervigilant, we have to be on guard, that things aren't safe, that we need to be on constant guardian mode, which completely takes away the bottom of the Maslow's hierarchy there. We don't feel safe. And that can lead to a lot of well-intentioned but very disruptive behaviors. And in addition, responders experience all of these stressors in addition to the daily stressors everybody has in life. When a responder responds to a disaster or is actually personally involved in the disaster, that experience can compound everything that's listed above. Surveys of emergency responders have shown their self-reported biggest stressors are financial, stress management, and relationships. One thing that I'd like you to be aware of with responders is that when financial impacts hit, when financial stressors hit, their go-to is to work a lot more overtime or to pick up a second job, usually in a response profession. They are, at that point, increasing their traumatic exposure and significantly decreasing their recovery time. Many responders pride themselves on being part of the USAR teams, the FEMA teams, and responding to disasters, but this can have the similar effect and can often be an attempt to avoid the stressors of daily life by staying engaged in something that's at a high crisis level that stimulates that threshold of feeling needed and feeling impactful in a responder. One of the things that I'd like to make aware or make you aware of for yourselves, and then also to help normalize the experience for responders or for their families, there's a series of documentaries. These are just two, there's many out there, that rely on the power of personal testimonial. They're pretty raw videos with responders talking about the impacts that the jobs have had on themselves and on their home lives. Status Code 4 did a great series called Lifelines that we help support. Code 4 Counseling out of Colorado is currently running a series called Start the Conversation. It's great not only for the education of counselors and other clinicians, but again, for responders themselves and for their family members. For other resources, we've got plenty on ResponderStrong, and thank you. That's the end. Let me shift out of screen sharing here.
All right. Thank you so much, Rhonda, for that wonderful presentation and all the information that you shared with us. Looks like you're still sharing that screen. Oh, there we go. All right. So I'd like to move on now to just ask our guest experts just a couple of questions related to their topics. And let me share my screen real quick. And Rhonda, I'd like to start with you. If you could briefly, just for the sake of time, let me get this up. Oh, shoot. Okay. Sorry about this. I have to go to my screen here. Okay, maybe if I start, how do I do this? Okay, there we go. Rhonda, could you recommend any specific strategies for engaging crisis contacts who identify as first responders?
Absolutely. I think the most important thing that you can do is normalize what they're experiencing. And that's what I had hoped to empower you to do with all of those statistics and those documentary resources, is to understand most responders won't openly admit they're struggling, but statistically we know most responders are struggling with stress injury. And the other thing that I think is most important is that you recognize our cultures ingrain a very deep sense of shame in us when we're admitting something that we feel doesn't meet the image of an emergency responder. You're being able to address that and to acknowledge or to recognize that your client is coming from a place of shame, to normalize that and reassure them that this is normal, to justify that a human reaction to the amount of vicarious trauma they're experiencing is totally normal, and it is also treatable and reversible. So you're doing the two-pronged. You're dealing with the shame and you're also giving hope.
Great, great. That's wonderful. Thank you. And then, Dr. Caulkins, I'd like to bring you in on the second question. I'm wondering if you could share any specific resources for referring first responders for follow-up care and additional support.
Yeah, thank you. Well, first I echo everything that Rhonda said, and then I throw out too, if anybody's interested in the ideation rates, planning rates, access to means. In my state, I did a statewide survey of all responders. Happy to share that with them. I do know the actual suicide rates as well, because I, including retired and left employment in my states, because I worked with credentialing agencies. So if anybody's, just a side note quick, anybody's interested in that, happy to share. But it's only for my state. So my center is working on a project at this time, because this is a problem. We don't have that mental health provider net that understands our culture. And just like military folks want to be helped by somebody who has a grasp of their culture. Same thing with emergency responders as well. Very important. We do have some peer support groups that have started with private ambulance services. Our St. Paul Police Department has an an EAP plan. And then there's something called the MinFire Initiative, which is a really important peer support function in our state too. And you just go to minfireinitiative.org and learn about that. And I know there's other things throughout the country. So those are some resources, but what we're working on is something to help the mental health providers understand our culture. It's not practical to put responders through school to make them mental health providers. So you can't, that would be a great thing, but we can't do that wholesale. So what we're doing is collecting a list of mental health care providers that are interested in being on the list, that we get their credentials, make sure they're licensed in the state, any other specialties they have, we keep track of, EMDR, ART, CBT, DBT, et cetera, their discipline within mental health. And then we put them through, we're working on a training program, an education program, a little bit on suicidology, because most mental health professionals don't really have a lot on the theory and that piece. They know all about the mental health piece leading up to it, but not that chunk generally. And then take them to where we make police, fire, and EMS, the colleges, where they come in, sit in my classroom. I'd have them watch scenarios, watch paramedic students starting IVs on each other, just kind of what does it take to become one? And then tours of stations and bases, to ride-alongs, and in the case of dispatch, a sit-along, and then we put them on the list, and then we have a feedback mechanism. Think of it like TripAdvisor, right? You go someplace and then you rate on stars, and with a QA process, and we just make sure that quality is there and that kind of a thing. So that's what we're doing here. I'd really like to encourage that other places as well.
Wonderful, thank you. And we did get a question too for you, Chris. If you could share some of those resource links that you mentioned, if you have them available or handy, I think that would be appreciated by our participants as well, because that's a lot of good stuff there that you shared.
Lydia, may I jump in for a second?
Yeah, absolutely.
Oh, great. Chris, I definitely want to connect with you afterward. ResponderStrong is also doing something similar in Colorado with the intention of national expansion. So those resources or similar resources are available on ResponderStrong.org. But I happened to notice in the chat box, somebody mentioned that everything we're describing in the response world is very similar to the world of crisis counselors. And that's something we've acknowledged since the beginning. Crisis counselors in particular, but mental health providers in general, are the emergency responders of the mental health world. And we recognize a lot of similarities in our culture, particularly putting others first and relegating self-care to the back burner, if anywhere, even on the stove. And that a lot of the exposures that the mental health providers get are very similar to the vicarious trauma that responders get. And we know that the information we're putting out there, we're hoping not only changes our culture, but changes all the cultures who are involved under the broader emergency response umbrella. We know that emergency responders aren't all dispatched on the first tone, that many come into play later, whether it's in a disaster capacity or in taking care of the responders.
Yep,
Okay.
I agree with that. And I always tell mental health professionals when I present to them, because I've made the presenting circuit to different places, exactly that. You save lives just like I do. And you know what? Your success rate is probably better, because in my state, we have a pretty good cardiac arrest save rate, about 10%, which is pretty good. That means 90% don't make it. You save more than that. You just can't see it. It's like preventing traffic accidents. So I want to echo that and say what you are doing is so important, and thank you for that.
Okay, great. Thank you. Let's move on to Shye Louis, Program Manager of Clinical Best Practices with the Lifeline, who will speak to us about some tips for connecting with first responders.
Sure. Thank you, Lydia, and thank you to the speakers who have shared such great information with us. I hope that our centers who are part of the Lifeline and part of the DDH will use this recorded webinar potentially, as well as the tip sheet I'm about to talk to you about a little bit more in detail with your crisis counselors. The Lifeline's been engaged with a few different organizations of first responders, police, firefighters, things like that, who've given us the feedback that folks are sometimes hesitant to reach out to the Lifeline because they aren't sure if they're going to get someone who understands their culture, who's comfortable with them, who is going to be able to connect with them the way that they want to be connected with, in addition to some of the other fears about active rescue and things that our panelists have already recommended. So we started to engage in a little bit of research, so consulting with first responders, and our nearly complete and ready to release a bit of a tip sheet on our network resource center that gives some additional guidelines, recommends some training for how crisis counselors might better be prepared to interact with first responders and might create a better environment where folks would feel safer making a call to the Lifeline and getting the help that they need if they're a first responder. So the tip sheet starts out with some of the same kinds of information, just a more truncated format of information about first responder culture, some things that could be affecting folks who are first responders. But I wanted to use my few minutes today just to talk about some of the very specific crisis counseling tips and things that crisis counselors might want to use and consider when working with people who are first responders. And the first is just basic crisis counseling, in addition to your regular crisis counseling and suicide intervention skills. So with first responders, so we've gotten some feedback that it's really important to invest a lot of time and energy on building rapport and creating trust up front, and to being mindful about being real, being genuine, using very genuine language. Some of the kinds of more flowery crisis counselor language that we use may not be received as well by first responders. So making sure just to be as real as possible while also maintaining your professional skills is really important. So in focusing on that time to build trust, you may also get a lot of questions at this point about confidentiality, and it's important with any caller, but I think especially with a potential first responder, to not hem and haw or sound uncertain about confidentiality, and to give accurate information right away about your confidentiality policies at your centers. Callers also need the space, or whether it's a chat contact or any other kind. I tend to default to the word caller, so apologies for that. But giving people space to process their stories. A lot of times folks need to do some cognitive processing before they can get to that emotional processing. They might also be testing the waters with you to see if you can handle hearing some of the stories that might be more shocking. So it's really important that crisis counselors are prepared and are able to not be shocked by some of the things that a first responder might say about their experiences, because some of those experiences are very, very different from the kinds of things that we might hear about in regular calls. Somebody already talked about sort of that gallows humor. It's a wonderful coping mechanism, but sometimes crisis counselors don't understand and connect to it very well. So being prepared for that emotional disconnect and gallows humor as the story is initially being relayed is really important. And then the normalization that Chris talked about, I think it was Chris, talked about how important it is to normalize feelings, and that what people are reacting to are normal reactions. And those are really important skills to bring to the table when working with a first responder. When talking, and Lydia, if you could move forward for us, when we're talking about the next piece, which is talking about coping skills, a couple of things to think about that are sort of different. So when working with a first responder might be, just really sort of focusing on self-care. We always talk about that, but you may want to change your language. Some folks don't respond as well to the self-care language, and they might respond to more language so that don't feel so counselor-y. That's a word. It's not a word, but they might respond better to language that's a little bit more direct about what kinds of skills you want them to use. Managing or coping or preventing, sort of those kinds of words might be more heard and more adapted as you're talking about the typical kinds of self-care strategies, but really stressing that, reviewing the person's support network inside and outside of their work families. So, and making sure that we've kind of included that and talking about the resources that could potentially be available to that person. Also wanted to talk about offering suggestions for techniques that can really help with some of the kinds of things that have really been shown to help with some of the kinds of things that folks experience in terms of mindfulness techniques, relaxation techniques, breathing techniques. Again, some of these things can feel off-putting to certain folks in terms of just how counselor-y, I'm going to stick with that word, they are for folks. And so sometimes if you pick different word choices and instead of mindfulness, really just talk about breathing techniques, or if you frame it that these are techniques that athletes use, that they're techniques that special forces units use to prepare them for their work, and kind of frame them in some of those kinds of ways that can be heard and accepted differently. So sort of thinking about those choices when you're talking about coping skills can make a difference to the rapport that you have with the first responder. When talking about referrals, if the person is willing to take a referral for face-to-face mental health counseling, use some of the kinds of search terms in your databases or whatever kinds of referral lists that you have to look for places that might offer like cognitive behavioral therapy, exposure therapy, other kinds of things that have been shown to work well with folks who are first responders. They're certainly not the only types that can be of assistance, but many first responders have reported finding those types of therapies helpful to them. Also talk about the desire for privacy when trying to make that referral. They may not be comfortable making a face-to-face referral. You may want to offer something that's outside of the person's town, maybe a little bit farther away, so they're not as likely to see someone they know. Think about other kinds of ways that a person could maintain privacy and have that conversation very clearly, because even if the person isn't saying that they're concerned about that, they probably are, so it's a good point to raise and to help them brainstorm past any possible barriers that they're seeing around their desire for privacy. Could there be online options for services, an online support group, or other things that feel safe to them, depending on your agency's individual policies about online referrals? You may have something that's available to them for in an online kind of way that might feel more private for folks. Also, just administrative considerations for crisis centers to think about is, again, anything that you can do to help get your crisis counselors feel more comfortable with the culture and with the community. So if you can do any kind of mutual in-service training with different first responder groups in your community, so you go there and present about your crisis services, they come to your center and meet your staff and present about crisis services. If you can go to different training events that they have where they're training new people, and you could train on a topic that relates to your crisis center, so that some kind of mental health training that you could offer, that helps folks to feel more comfortable with crisis lines the more they know about us. Could you get your staff to maybe go on ride-alongs, anything that's going to help with that cultural competency. And then any other additional trainings that you can offer to your staff around working with first responders are really helpful. The tip sheet's going to have a couple of recommendations in addition to the materials that are shared, that were shared by our speakers earlier. So there's a couple of different courses that we found that are available online. SAMHSA's Technical Assistance Center has some materials, and we'll include all of those in the tip sheet that will go on the NRC very soon, and I'll give that information to Christian and Lydia to put into the materials following up from this webinar. So I'm mindful of the time and I've used it all up and I'm so sorry.
That's all right. Thank you, Shye. We're looking forward to seeing that great resource. So thank you so much for that. We are exactly at 3 p.m. Eastern. However, I don't know if our guest experts do have just a couple more minutes to perhaps answer some questions that may be coming through. And I'm looking at, and again, use the chat box if you do have a question. I'm looking at a question. Do EMTs have any peer support lines? I'm aware of police peer lines, but don't know if their effectiveness or degree of utilization. I don't know if Rhonda or Chris, you have any information about that?
Yes, we have peer support. In particular, we've been working with a company called iRelate, IREL8.org. They created an international platform for peer social support around mental illness and mental health concerns. They are just finishing up the beta on a version for responders called ResponderRelate that was funded by Global Medical Response, one of the largest EMS organizations in the US. That's intended to allow confidential connection with peers regardless of geographic location 24/7, that also allows specialization in talking about a specific area of interest, whether that's EMS, post-traumatic stress, alcohol consumption, whatever. That should be out this summer. There's more information about it on our site.
Okay, great.
I also
Go ahead.
want to mention one of the very first police organizations that reached out to the Lifeline since I've been with the organization. One of their big points of conversation was about the different peer support lines for police that have sprung up, and the concern, the dual concern that those peer hotlines have the advantage of having folks who know, they've walked the walk, and so they can have a more real conversation with the responder, but they don't necessarily have the suicide or crisis intervention training or follow particular evidence-based standards in terms of how they work with the individual in crisis. And then the balanced with the concern that maybe Lifeline centers don't have the cultural competency to do that, and how could we bring the Lifeline more up to speed so that they could feel really comfortable recommending the Lifeline as a place that would be culturally competent, but that also meets good standards around training. Not to say that the other peer lines don't, they spring up individually and may or may not have good training on suicide prevention skills and crisis counseling skills. So sort of trying to balance that. So anything like we are doing with this webinar will help Lifeline centers to be better and will help bolster any other efforts that are being put together. We want them, the public resource, to be as strong as possible in terms of cultural competency. So I'm so happy that we had this webinar today.
Okay, and I've also seen, Chris, that you posted some links to resources. Thank you so much for that, Dr. Caulkins. And the slide that you're seeing now is our contact information in case you have any other questions or a follow-up question that pops up after you get a chance to digest all this information. But I would just like to thank all of our guest experts today for sharing this information. I think this webinar was wonderful. And thank you so much for the opportunity to share this information and to share your expertise. I truly, truly appreciate it. And from what I'm reading, it sounds like it's been useful to our centers as well. And also a big thanks to all of you for attending and participating in this webinar. Lastly, I just want to mention that we understand that this topic may be triggering for crisis center staff, and really encourage you to be mindful of that and to practice individual and group self-care as you can. And so thank you so much for tuning in. Again, thank you to our guest presenters, and I hope you all have a nice day.